focusing down, I don't know from a primary care perspective, but from thinking about CUP, sorry.
MUO, or yeah.
MUO, peer review. It's something that when I was a GP, I don't think it was something that entered my consciousness particularly, and it's something that I kind of, now it's become, it's a cancer with the worst, or the malignancy with the worst prognosis of any of the cancers. From your experience, have you had experience of patients with this and ways to diagnosis of CUP particularly?
I've never seen anybody, what I would like to know is how you tell people they've got that and how they cope with how come you don't know.
Hard, yeah. I mean, I think it's hard enough giving somebody a diagnosis of cancer, but then having to say, but we don't know what sort, where it's come from. It's a really sort of tricky, sensitive thing, and it's something that you need to be face to face with, and actually knowing what the patient has already been told is really useful. One of the things that we try and do is to make contact as early as possible. I phoned a lady earlier today who was seen in an outpatient appointment yesterday who's got presented with bony mets, and it's just making that contact, giving the details and having a chat with her to know that there's somebody at the end of the phone, and then we'll be discussing her at our MDT and sort of working out what we're going to do next. And they're all, as I say, very different, but it's just supporting them through this and trying to explain it. And it's often the relatives as well that really struggle with grasping it. I mean, sometimes we do find the primary, and that's lovely, and then we can sort of transfer the key worker across.
It's quite difficult because actually now that malignant disease is behaving very differently than certainly the way I learned, and so patients are presenting with very odd things. I saw a patient this week who's got malignancy in his maxilla, and actually almost certainly it looks as though it's a lung primary, and there's metastaside there. And I think where you're dealing with this, because I think it's a really good question, that actually part of palliative care is actually about maintaining hope. And the difficulty when you have to say to somebody, we think we're giving you the treatment that might work, they'll go, well, what are you actually treating? And you have to say, well, I don't know. It does become not a best guess, but it's actually about the understanding the natural history of a lot of disease and thinking, well, actually, these diseases present like this, so there may be sort of two types of malignancy that you think, well, actually, there's cross-cover in the oncological management of that by using these drugs. And actually, it's difficult then, isn't it, to predict what the outcome will be. And that's where the support becomes so crucial.
And I think some can trip you up as well, can't they? Because you can have somebody that 20 years ago was a CA breast. So you might automatically think, brilliant, that's all right, we know what this is. This is a recurrence, because it can recur later on. But obviously, chemotherapy is a carcinogenic in itself, radiotherapy. So they may then come back under Jane with, actually, no, it's not. We don't know where this was come from either. And all the markers that you might initially have a few markers to go on, but they're all up in the air. So that's, again, difficult. That not only have you got cancer you don't know where it's come from, you've got a second one in a lifetime, and you've got all your previous experiences to work out on from, and just not knowing. It's sort of devastating, isn't it?
I think that's one of the real benefits of the MDT, the CUP MDT, because there you pool a lot of sort of expertise.
It's very confusing for the patients, and it delays their diagnosis in a way, doesn't it? And certainly the patient that you're thinking of that we've had recently on head and neck CNS was thought to be upper esophageal, and then was thought to be retropharyngeal, and now it seems it might come back, and you hardly dare to tell the patient yet you get to sort of reassure him, but it's support all the time, because every time he gets a plan he feels a bit better again, doesn't he?
And it's just knowing that there's somebody there to guide them through, because it can seem so long-winded to get a diagnosis, and you're doing this test and that doesn't give the answer, something else, and it's frustrating for us, and it must be horrible.
Extraordinarily difficult.
And of course the pool is our main centre, so there's the liaison, so it's very easy for things to get muddled as well, isn't it?
Is there a commonality of presentation that we in primary care should be thinking about?
I don't think there is. I think that's the problem, to be honest. I mean, a lot of these can be sort of picked up incidentally. We were talking yesterday about the routes and the directions that the patients come from, and they're all over the place. They can, come in through ED. Sometimes it might just be a CT that's been done for whatever reason, completely different, unrelated, and it just picks up liver mets or something like that. And I think we're lucky now because people know that we're quite a reasonably well-established MDT in the CUP service, so they're very good at just phoning us or pinging off a referral, and we don't really care how that happens, so long as somebody just lets us know, and then we can sort of pick it up and go with it, really.
I want to come on now to think about some of the other presentations of cancer, and we, particularly from a primary care perspective. I wonder if any of you feel able to share patients that you've had with either metastatic spinal cord compression or hypercalcemia, or one of the emergency presentations of cancer. Is that something that is a familiar experience, or is it something that still fills you with terror, as it does me?
I had a lady with hypercalcemia quite recently. She'd had a chest x-ray to investigate chest pain, I think it was actually initially, but showed a lung mass, which spread off respiratory, declined any treatment, any investigation, anything like that. Really went off colour very, very quickly, did some bloods the next day, came back with a calcium of 4.2, I think. 4.2. It was quite small, yes. So admitted her. She was rehydrated and presumably given bisphosphonates and discharged with a planned GP monitor calcium and treat if it goes up again, which I thought was really helpful. It did go up again and she was admitted to Forest Home and died shortly afterwards. But I was intrigued as to what in general practice I could do to treat calcium at that sort of level.
Yes, and I think Simon, I was going to say, because you always said very rightly, I think, stop and think: is this the right thing to do? This is a potentially end of life event. That if as the calcium's raising, things your metabolic control of your calcium has changed. Calcium's over 3, as you know, are an emergency and need treating as directly as possible, and that treatment is rehydration. But should you be thinking about that in all patients? Should you be admitting patients who are terminal towards the end of life? Because a very large percentage, I can't think of the percentage off the top of my head, of patients towards the end of life become hypercalcemic. Does anyone know the statistic? It's high. It's a metabolic and apparently a plastic phenomena that Simon might be able to look it up for us. But we certainly see those calciums that I suppose are beginning to raise, that the symptoms are actually really quite insidious and difficult to pick up. Have you come across those? What sort of symptoms do you?
Constipation, confusion.
Yeah. Constipation.
Elderly people on drugs. You could mask it from that, I suppose.
Yes. Yeah.
One of the common symptoms that's often forgotten is vomiting.
Vomiting. Yeah.
Was it? Yeah.
And I guess even for things like CUP, it's as an index of suspicion, isn't it? Trying to think. How many patients do you come in through that route, through the acute oncology?
Well, I've seen a few on the ward, but I tell you what, it's difficult with you guys even being out there as well without all those gimmicks. You haven't got the bloods actually handy and everything else. I've had battles with doctors in hospital with high calciums, and they're going, "We're just going to check a parathyroid." Well, hang on, can you humour me? Hydrate her, get it sorted. This lady's got bony disease. Let's treat that, and then I'll let you have your parathyroid, which will probably come back in 48 hours. But can you just humour me in the meantime? And so even within hospital, it's a battle. And you guys are trying to admit, I know you'll be on the blower to the med reg. I think I've got this hypercalcemic patient, And the battles you can have sometimes getting through and saying, actually, can you review this patient? You haven't got the ability to bring them in, bit of IV access while we wait and see. Let's see what the bloods are doing. You guys are doing it off the hoof, and that's so it's very difficult, isn't it? And so, and like I say, we battle in hospital with the amount of times I've spoken with doctors said, you really need to, and it'll be a patient. It is a recent one was a young person, I have to say young, she was in her early 50s, and we're all... That's
Yes.
She presented with bony mets, hypercalcemic, with spinal cord compression, and a new breast on holiday down here, so no indication at all. So, you know, and she's been getting more unwell. She was wheelchair bound, her own local area. She'd been in and out of not only the GP referred for further investigation. She'd been into a major hospital, been investigated, and it took coming into ED with pain for balls to start rolling and people to realise, oh my God, actually she's seriously ill. So, you know, it's difficult to expect you guys, whilst you haven't got any of that extra bit, you've got 10 minutes with a person who's telling you, I don't feel very involved. I've got this, I've got that, and for you to try in that 10 minutes to say, actually, yeah, we can pinpoint this down, when I see doctors on the ward that cannot pinpoint things down. So
there are different scenarios that you're going to come across in. There's the unexpected finding, so it may turn out that that's how they present with their malignancy of unknown origin. So so that you're investigating somebody who's unwell. Then there are those people who you might think it might be a problem. So the predictable cancers that have an association with hypercalcemia. And actually we were look at one of the cases that I was going to discuss, I might just sort of mention it now, was a young girl in her late 30s who'd had a renal cell cancer, and she presented with vomiting and abdominal pain, and she had a calcium of 2.84 and renal cell carcinoma. So everybody was saying, well, you don't get hypercalcemia with renal cell cancer. That actually 2.84 you probably wouldn't treat, and it probably isn't what's causing it anyway. So it raised lots of discussions. And then there are those who had an episode of hypercalcemia that you were asked to monitor, and actually a decision about whether you treat it again in the future, so that it may be at risk. And actually the thing you need to know is whether or not the previous treatment of hypercalcemia has helped, because as soon as you have malignancy-related hypercalcemia, your prognosis is going to be less good, and also the frequency or the rate at which it recurs. So that actually, if hypercalcemia recurs very quickly, then actually you're not looking at managing it very well. But I think the scenario that you're trying to avoid, and I've been caught out on this, is where somebody presents with hypercalcemia, and actually you get excited and you think it's a malignancy, and actually it turns out they've got a parathyroid tumour. And when that's happened once, you don't forget it. And interestingly, this young girl that we looked after, who had renal cell cancer, she was bedbound because she'd had a malignant spinal cord compression something like 18 months beforehand, and had presented with symptoms. People thought she was in obstruction. In fact, she was constipated. But we ummed and ahed about the treatment, and we did rehydrate her, but actually checked her parathyroid, which actually we didn't wait. We treated her before we got the result. But actually, her parathyroid was incredibly low. So suggesting that this had been going on for some time, and almost certain was related to malignancy. So actually a tumour can behave, just because books don't say this cancer doesn't do that, just challenge it, because it's I just see it happening all the time. And in fact we made the decision in her that actually we rehydrated, and her symptoms resolved. In fact she was constipated as well, so we managed that and sent her back into the community with a view that now that she had reached the end point of her treatment options, that actually treating her calcium was not going to be very helpful. And interestingly, the clever oncologists said that actually she wouldn't be somebody who's got a chronically low parathyroid level, meaning it's a chronic hypercalcemia that's getting slowly worse, that you wouldn't treat with IV bisphosphonates, and actually the treatment would be oral bisphosphonates with vitamin D in the community to avoid something that you'll all know about, hungry bone syndrome. And that's what she was, that was going to be the plan, because in fact she had extensive disease. So there's it's amazing that sometimes in situations that hypercalcemia is not always as straightforward, and actually can present in a range of different ways.
So as you were saying, because they sent back saying, can you manage the community, rather than just saying that, actually stating within the EDS, as
Yeah.
you said, would have been a lot more helpful to you than, thank you GP, can you follow this up?
Yeah.
Because you're like, well, what do I do now?
Yeah.
So
That will
would have
almost
been-
inevitably end in an emergency, won't it? Unless you're
Yeah.
proactively
And
following
the question
up.
is, when you do it, do you do it once a month, or do you do it when they've got symptoms? And
Yeah.
actually, it's understanding that. And
Yeah.
Yeah. And that's what sometimes is needed, I think, isn't it? Between the, I've seen some EDSs that if I was a GP, I'd go, well, hang on, I might as well just throw that in the waste paper, but it doesn't even need confidential waste because there's nothing on it. And I think some of the doctors
Yeah.
sort of...
The name is
little
helpful, isn't
doctors-
it?
And I look thinking, I know what this patient's had done this weekend, and I just want to
Yeah.
check with the GP and everything, and I look and I think, that GP, unless her crystal ball's working today, there is no way
No,
she
no,
knows what's
can be
happened.
hopeless, isn't it?
And it can be really awful, and I think, like I say, a lot of that communication, and even just that, rather than GP, please check this, what I need checked, why I need checked, and action if can be beneficial, can't it?
I think this evening's session's been really useful. The main take-home message I would get is that the patients presenting with malignancy of unknown origin is really varied, and the main message would be just to speak to us, keep the contacts between the GPs and us. We can, always find out what the next step should be, support the patient in the meantime, and get back to you. But just stay in contact.
If I had a room full of GPs, I'd probably be saying to them, any queries, any concerns about acute oncology, not sure what to do, where to go, please give us a call. It's 01305 256987, and hopefully we can help, or at least pinpoint you or send you in the right direction of somebody that can.